Hello, welcome to our presentation on high-risk assessment and the CARE program brought to you by Breastlink. Thank you for joining us for what is sure to be a very informative and exciting discussion. Presenting this evening is Dr. Valentina Bonev from Breastlink, and we have a special guest who will join us for the Q&A portion, Shabnam Asgari, who is a genetic counselor from Ambry. She will be adding her expertise as a genetic specialist and a representative of the CARE program. I'm Stephanie Landon from Breastlink, and I will be your moderator for this evening's discussion. Before we get started, I just want to mention that we're going to hold all questions until the end of Dr. Bonev's presentation. If you'd like to ask a question, please type it into the chat box and I will read it to Dr. Bonev. If you have any issues or technical questions at any point, please feel free to message me. Now, I'd like to introduce Dr. Valentina Bonev. Dr. Bonev is a fellowship-trained surgical oncologist and high-risk breast cancer specialist. She earned her medical degree from the University of California Irvine School of Medicine and received fellowship training in breast surgical oncology at the Lynn Sage Comprehensive Breast Center at Northwestern University in Chicago. Dr. Bonev has authored multiple research publications and has been active as a volunteer teacher. In addition to the many services Dr. Bonev provides at Breastlink, such as treatment of both malignant and benign breast disease, she also provides assessment and management of patients with high-risk breast factors. I'd like to welcome Dr. Bonev now.
Thank you, Stephanie, for the introduction. Hello, everyone, and thank you for joining us tonight. So the topics we're going to talk about are you high risk for breast cancer and should you get genetic testing? Some of the objectives are, what are the risk factors for breast cancer? Who is considered high risk for breast cancer? Who should get genetic testing? Introduction to the CARE program. What is my role as a breast surgical oncologist in navigating your care and how you can reduce your risk. So let's just get into the talk. So first, some breast cancer statistics. 1 in 8 women will develop breast cancer. The average risk of a woman developing breast cancer in her lifetime is 12.5%. You may see posters that say 1 in 8 women, 12% risk. It's technically 12.5%, but you could also round it up to 13%. The American Cancer Society estimates for breast cancer in the United States for 2022 are almost 300,000 new cases of invasive breast cancer and over 50,000 new cases of ductal carcinoma in situ, or DCIS, which is technically a stage 0 breast cancer. So let's talk about some breast cancer risk factors. So first, we're going to talk about non-modifiable factors, which are factors you can't control. So that includes your family history. As the saying goes, you can pick your friends, but you can't pick your family. So risk factors for breast cancer include a family history of breast and/or ovarian cancer, family members who may have tested positive for a gene mutation that increases your risk of breast cancer, and one of those is the BRCA or BRCA gene. However, there are other genes associated with an increased breast cancer risk, which we'll go into in a later slide. Although I did include some genetic syndromes that can be passed down in the family. Hereditary breast and ovarian cancer is associated with the BRCA1 or 2 mutation. Lee-Fraumeni syndrome, which is associated with a P53 mutation. Peutz-Jeghers syndrome, which is associated with STK11 mutation, and Cowden syndrome with a P10 mutation. There's also hereditary diffuse gastric cancer, which is associated with the CDH1 mutation. So all these mutations increase your risk of breast cancer, but there also may be other cancers that you may be at risk for, such as ovarian cancer or gastric cancer and hereditary diffuse gastric cancer. The patients who have an ancestry of Ashkenazi Jewish are also at increased risk. And the reason why is that a patient who is Ashkenazi Jewish has about a 1 in 40 chance of having a BRCA mutation, versus in the general population, it's a 1 in 400 chance. So 10 times higher in Ashkenazi Jewish. Another factor that you can't change is getting older. So as you get older, you have increased likelihood of developing a cancer, such as breast cancer. Now, there are other factors, lifestyle factors, which are modifiable, which you can control. So patients who are obese, who consume a lot of alcohol or have a history of using hormone replacement therapy are at increased risk for breast cancer. And the reason for this is that you have increased circulating levels of estrogen. I get asked all the time, well, what about my diet? What about if I drink wine? Is this allowed? Are there certain foods I can eat or should avoid? Can I eat sushi? Can I eat nuts? So what I recommend is a healthy diet and everything in moderation. Some more breast cancer risk factors include your reproductive history. So patients who are at higher risk have a younger age of their first menstrual period, nulliparity, meaning not having any children, older age of their first live birth, and older age at onset of menopause. And the reason for this is because all these factors lead to increased levels of estrogen. Certain factors in your medical history can also lead to increased risk factors. So you are at increased risk if you underwent chest radiotherapy before 30 years old. And this usually occurs for patients who are treated with Hodgkin's lymphoma as a young age. And as you can see in this diagram here on the right, the reason being the white area corresponds to the radiation fields that a patient has undergone. And it does capture part of the breast, as you can see here, central part of the body, superiorly, and then laterally, and then also including the axilla or the armpit where there are lymph nodes. Having a prior breast biopsy, for example, it may have shown lobular carcinoma in situ, which despite the name is actually not a cancer. However, it is a risk factor for breast cancer. Also patients who may have had a biopsy that showed atypical hyperplasia. There are two different types of atypical hyperplasia, atypical ductal hyperplasia or atypical lobular hyperplasia. These are abnormal cells, which is what atypical means, that are occurring either in the ducts of the breast or in the lobules of the breast. And having any of these on a breast biopsy is an indicator for increased risk and can actually increase your risk in either breast of around 20 to 25%. Another factor is having dense breasts on mammogram, which I get asked about all the time by patients and primary care providers. And we can actually spend a whole talk just talking about dense breasts. It's actually required by law that if you have dense breasts on mammogram that you be notified, but it's up to the ordering physician who ordered the mammogram what to do if you have dense breasts. So let's talk about dense breasts for a moment. So this is showing you 4 categories of breast density, which is actually going to be used by the radiologist to describe your mammogram. So the first category is breasts that are almost entirely fatty. So it just means that your breast is made up of more fatty tissue. It doesn't mean that you are overweight or obese. It just means that your breasts happen to have a lot of fatty tissue, and that corresponds to the yellow on this image here. The next category is someone who does have fatty breasts, but they also have glandular tissue, and that's going to be evidenced by the purple here. Those who have more of the glandular tissue are going to be more dense, and you can see, compare number 3 to number 2, the increased density. And those who don't have fatty breasts at all but just have very dense breasts, exemplified by all this purple that's occupying most of your breast, these are going to be extremely dense breasts. So let's see what it looks like on a mammogram. So this is going to be a primarily fatty breast. It's pretty easy to see any abnormality. This is going to be a breast that's mostly made up of fatty tissue with a little bit of glandular tissue there. This is going to be a heterogeneously dense breast. So it's not going to be fatty, but it's going to be dense breast tissue throughout. And then this is an extremely dense breast. So comparing image D all the way to image A are completely two different images. In A, it's going to be a lot easier to see a cancer or a precancer, which I'll show you on the next slide, versus in D, it's much harder to see. What I tell my patients in order to make an analogy or describe what is dense breast tissue, I say, well, when we look at the mammogram, it's like looking at a snowstorm. And it's hard to see anything abnormal because it's caught up within this snowstorm. So to show you that, we look at a fatty breast where a very small cancer, less than 1 centimeter, less than, looks like 5 millimeters, was detected on mammogram. And if you don't believe me, we can at least believe the red circle that's indicating that. But if you compare that to a woman with an extremely dense breast, which is all of this white appearance here, which I call the snowstorm, there's actually a large cancer, which is hard to tell exactly where it ends, but we know it's at least something like that. So it's definitely over 1 centimeter, and it was hard to detect. This small cancer could not have been detected because it was lost within this snowstorm or dense breast. So we know that the radiologist did find this cancer. They marked it with the red circle, but unfortunately, it was not caught earlier because the patient had dense breasts. So that's why it is considered a risk factor for breast cancer, and it is a great idea to see a breast specialist to talk about what to do if you have dense breasts, and to do any supplemental imaging in addition to the mammogram, so that you can catch a cancer sooner, as in this case, versus a cancer that is larger and has the potential to spread throughout your body. So who is high risk for breast cancer? So we just went through modifiable and non-modifiable risk factors. But more specifically, we can actually calculate an estimated lifetime risk of breast cancer using a probability model. And there's a few models out there. Gale has been around, I think, the longest. There's also BRAC, Klaus, and Tyrer-Cuzick. Personally, I use the Tyrer-Cuzick model. I think it's the most accurate model. I believe all these models are actually for free, and you can download them off the internet. If you were to search for the Tyrer-Cuzick model, you can either search for that, or it's also known as EBIS with this symbol, the International Breast Cancer Intervention Study. And it asks a whole bunch of questions about your personal family history, also your mammogram findings, whether you have dense breasts or not, and you can get an estimated lifetime risk of breast cancer. So what's considered high risk is if you have over 20% estimated lifetime risk of breast cancer using one of these probability models. And coincidentally, this is also what insurance uses to determine if you're high risk or not, and whether to approve any, for example, high risk screening, such as a breast MRI. So let's talk about genetic testing. Who should get genetic testing? So there's guidelines that the National Comprehensive Cancer Network, or NCCN, have put out there, and to help determine who should get genetic testing. So if you have family members who tested positive for a mutation in a breast cancer gene, such as the BRCA gene, then you are a candidate for genetic testing. You may have also gone under genetic testing yourself, but you may have only been tested for one gene, and that may have been negative. When genetic testing first came out, they were really just testing for just one or a couple of genes. So if you were tested for a breast cancer gene years ago, you're probably just tested for the BRCA gene. And there's actually many more genes that are associated for an increased risk of breast cancer. And I mentioned some of those genes earlier with the genetic syndromes, and there are some other ones which I'll mention in another slide. Genetic testing can also be very useful in decision making. I use it for patients who are diagnosed with breast cancer and we're trying to determine what type of surgery we're going to perform. Genetic testing can also help for decision making and how we're going to surveillance a patient. So if a patient tested positive for a gene mutation, it's going to change the way I approach managing this patient. And then, of course, if a patient is high risk based on the probability models I just mentioned, so over 20% risk, they qualify for genetic testing. Now, you can go more in depth with the NCCN guidelines. So this slide is taken from their guidelines for someone who was diagnosed with breast cancer and determining whether they should have genetic testing. So just briefly going over it, someone who's considered young age, so 45 years or less, should definitely consider getting genetic testing. Patient who's diagnosed with breast cancer or who has multiple family members with breast, ovarian, pancreatic, or prostate cancer should consider getting testing. A patient who has multiple family members with breast cancer, or a patient themselves who's been diagnosed with breast cancer more than once should strongly consider genetic testing. Patients with a triple negative breast cancer, which is an aggressive form of breast cancer, should definitely consider genetic testing. Male breast cancer, which is rare, less than 1% get breast cancer, should consider getting breast cancer. And then Ashkenazi Jewish, we talked about that because they have a 1 in 40 risk of testing positive for BRCA mutation. And of note, if you as a patient undergo genetic testing and you test positive, this can influence other family members such as siblings or children to get testing as well, and that could affect their management. So it's a little bit confusing with the guidelines. There's a lot within the guidelines. So if you feel like, well, I'm still not sure, should I get genetic testing? I think I have a family history, not really sure, then you should consult with a breast surgical oncologist. You can also see a genetic counselor, or another way is that you can participate in the CARE program, which is what I'm going to talk about right now. So the CARE program stands for Comprehensive Assessment, Risk, and Education. So what that is that women who are getting their annual mammogram can automatically participate by answering questions about their personal and family history. Your estimated breast cancer risk will then be calculated using the Tyrer-Cuzick probability model, and those who meet National Comprehensive Cancer Guideline Network guidelines will be contacted about getting genetic testing. And so there's two ways of doing it. One way, the easiest way, is a saliva swab, which is a swab that you just do of your inner cheek. The other way, which is actually still pretty easy, is just a quick blood draw. And to show you an overview of the testing process, so patients are identified as being qualifying to get genetic testing. They get information about the testing and why it's offered to them and how it could affect them. They undergo the testing, which is by saliva swab or a blood draw. They then get results saying whether they're positive or negative for a gene mutation. And then they are offered post-test genetic counseling. So anyone who gets genetic testing can get counseling. It's part of the CARE program. It's part of the testing. Even if you test negative, but let's say you have a really strong family history for maybe other cancers or several cancers, definitely you can see genetic testing, counseling. I mean, and if you test positive for gene mutation, you should definitely get genetic testing as well, in addition to seeing a breast surgical oncologist. So like I mentioned, there are a few genes that are actually associated with increased breast cancer risk. So the BRCA1 and 2, so there are two BRCA genes. BRCA is the most, I call it the famous gene because so many people know about it, but there are other genes, as you can see, such as ATM, CDH1, PALB2, PTEN we talked about earlier. We talked about STK11 and the P53 gene. So there are multiple genes. So someone who maybe was tested for breast cancer maybe 10, 15 years ago was only tested for the BRCA gene. But as you can see, there's all these other genes that should be included. So if you were to get testing now, you're actually going to get multi-gene panel testing, which means is you're not just getting tested for BRCA, you're going to be tested for all these other genes that are associated with the increased breast cancer risk. So let's just focus a little bit on the BRCA1 and 2 genes. So your risk of breast cancer is going to be over 60%. And if you have a really strong family history, it can be higher than that, 70, even 80%. And the general population, like I said on the beginning of the presentation, is 12.5%. BRCA2 breast cancer tends to be associated with the estrogen receptor positive breast cancer, which tends to have a favorable prognosis, versus BRCA1 is associated with a triple negative typically, which tends to be a more aggressive breast cancer. Now, both of them have an increased risk of male breast cancer, which is a very rare breast cancer, and there's a higher risk in the BRCA2 population. Both BRCA genes are associated with an ovarian cancer risk, and it can be around 60% with someone who tested positive for a BRCA1 mutation, and it's a little bit lower in a BRCA2 mutation. Both of them are also associated with a pancreatic cancer, higher in the BRCA2, and then prostate cancer, which is higher in the BRCA2. But the point is, it's higher than the general population. So just keep in mind, if you test positive for a gene, there could be other cancers that you could be at risk for. So just depending on that gene and making sure you get appropriate counseling and that you're referred to the appropriate specialists to monitor and treat these cancers. So if you test positive, you should definitely see your primary care doctor, again, to make sure that you're getting appropriate referrals. If you need to see any other specialists, you should definitely talk with a genetic counselor to get that detailed information about the gene that you test positive for and what you need to do next. And then if you test positive for a gene mutation associated with increased risk of breast cancer, you should definitely see a breast surgical oncologist. Now, keep in mind, even if you test negative, you still may be at risk for breast cancer or other cancers as well. So a negative test does not mean you will never get a cancer. It's just meant to determine if you have a genetic component of a cancer. So what is the role of a breast surgical oncologist? So I'm a breast surgical oncologist. I'm also known as a breast surgeon. I get asked all the time, well, am I a medical oncologist? I'm not. I get asked that because oncologist is in my job description. But no, I don't administer chemotherapy. I'm not a medical oncologist. That is a completely different specialist. Patients think I'm also a plastic surgeon because I operate on the breast. I'm not a plastic surgeon. However, I did undergo general surgery training as well as specialized training in breast surgery. So I manage patients who do have cancer, which includes the oncology aspect, but I also manage a lot of patients who don't have cancer, but they have other breast issues, and it could be benign breast mass, it could be breast pain. And then of course, I also see patients who are high risk for breast cancer or have a strong family history of breast cancer. So it's important to see a breast surgical oncologist or a breast specialist because they can determine your management if you test positive. And they can also determine if you're high risk or not and how to manage you. Ultimately, a breast surgeon is going to navigate your breast care. So for patients who are high risk or test gene mutation positive, you're going to get personalized management. Again, depending if you had genetic testing and you tested positive for a certain mutation, or maybe you tested negative, but you're still high risk, you're going to get an individualized plan on what to do. And so it usually includes increased breast surveillance, which is a breast exam every 6 months. So that is a physical exam every 6 months, annual mammogram, and then we determine what type of additional or supplemental annual imaging you should be getting. So that could be a breast ultrasound, or it could be a breast MRI. And again, that depends on your personal and family history. Then we can evaluate the need for genetic testing if you have not already been tested. And the next thing to talk about is, well, if you are high risk for breast cancer, what can we do to reduce your risk? So there are some risk reduction strategies. So I told you about the modifiable risk factors. So these are factors that you can, of course, modify or control in your life. So I said that patients who are obese have an increased risk. So that's why we encourage regular exercise. We encourage you to maintain a healthy weight and have a healthy diet, limit excess alcohol consumption, and if possible, limit long-term hormone replacement therapy. Breastfeeding is also considered a protective risk factor, meaning it lowers your risk of breast cancer. However, most of my patients I get, for example, if they've been diagnosed with breast cancer, their history of breastfeeding or not breastfeeding is years ago, so you can't really change that. But it's something to know if you're a younger patient. So bottom line, though, is just to, try and be healthy, maintain a healthy lifestyle. There are other risk-reducing agents or medications that you can take, which consist of a pill. And there are a few out there that have been proven in research studies to lower your risk of breast cancer. These can include tamoxifen or raloxifene. There's also what's known as aromatase inhibitors, such as anastrozole and exemestane. All of these are also part of NCCN guidelines, and they are recommended for certain patients who are considered high risk. We could spend an entire talk on this, and the best person who would actually be prescribing this medication and managing this would actually be a medical oncologist. So if your breast specialist thinks that these could be a benefit to you, then he or she will refer you to medical oncology to talk about this more in depth. The last way to reduce your risk is risk-reducing surgery, which is a mastectomy, and can entail of a bilateral prophylactic mastectomy. We could spend an entire talk on this. There are multiple different types of mastectomies that can include removal of the nipple areola or not removing it, and why would you keep it and why would you not keep it. There's also role for reconstruction, and there are different methods of reconstruction, which a plastic surgeon would go more in detail with you over, but can include breast implants or tissue expanders, or using your own tissue, which consists of a flap that can be taken from your back or from your lower abdominal region. So it's actually pretty complex, and this would be an individualized discussion with a patient based, again, if they tested positive, for example, for the BRAC mutation, or they were considered extremely high risk based on their history. So again, this is a huge topic in itself, and we could do an entire talk on prophylactic mastectomy, but it's something that if you're ever interested in, you can always talk to a breast surgeon about it and see if that option is right for you. So this concludes my portion of the talk. Thank you everyone so much for listening, and I'm going to pass it back to Stephanie.
Thank you, Dr. Bonev. Thank you so much. So we do have a couple of questions. So I'm going to get started reading those. Just open my question. Okay, so the first question that I want to read is, would you please provide an example or two of how genetic testing results could potentially impact surgical decisions with a breast cancer patient?
Sure. So an example would be a patient diagnosed with breast cancer who perhaps is an early stage, who is a candidate for a lumpectomy. They undergo genetic testing, and let's say they test positive for pathogenic mutation in a breast cancer gene, such as BRCA. We'll just pick BRCA again because it's the most popular, most known one. In that case, I would counsel the patient and tell them, well, you are still a candidate for a lumpectomy. However, with the BRCA 1 or 2 mutation, your risk of breast cancer in the residual breast tissue in that breast with the cancer or the contralateral breast is going to be very high. And it could be as high as 60 or even more %. So I would strongly counsel them about performing a bilateral mastectomy. So that would totally change the surgical plan for them. Now, I do have some older patients who, let's say, same thing, breast cancer, candidate for a lumpectomy, but BRCA positive, and they don't want to do a bilateral mastectomy because they say, you know what, I'm older, I don't want to go through this more extensive surgery than I have to, but they understand that they still are high risk, but they also, I guess, rationalize it, you know, I don't have as many years left versus, you know, younger patient, let's say in their 30s, 40s, you know, even 50s, of course. So it definitely changes the decision making for sure.
Okay, thank you. Okay, here's another question. My best friend had breast cancer 7 years ago. At that time, she had genetic testing, which came back negative. Should she get tested again?
It depends what kind of testing she got. So a lot has changed in the last 7 years. When genetic testing first rolled out, they really were testing in terms of breast cancer genes, just BRCA. So BRCA 1 or 2. So that's just 2 gene panel. And now, as I showed you before, there's a lot of other genes that we have now know are associated with breast cancer. So if they had a very limited panel, such as just testing for BRCA 1 and 2, and it was negative, they potentially could still test positive for these other genes that we now know are associated, such as PALB2 or the NF1 gene. So it's something for them to consider, and they can always discuss with the genetic counselor as well, or their physician.
Okay, here's a good question. Would you recommend genetic testing if you are adopted and don't know your family history?
Yes, so actually, that's actually part of the National Comprehensive Cancer guidelines. If you don't know your family history, which is typically the case in an adopted patient, genetic testing is recommended. It's up to you if you want to proceed, but reason why it's recommended is we have no idea about your family history. And so for that patient, I would not do a limited panel. I would do a more extended panel looking at potentially other disease processes such as colorectal, pancreatic. So not just breast, because again, we don't know anything about your family history.
Okay, here is another question. My sister had breast cancer at 38. She had genetic testing and was negative. Do I still need to be tested?
That's a good question. So, you know, the sister and the 2 sisters, they obviously have different genetics. Their DNA is not, I guess, identical. So, I mean, even though one tested negative, potentially the other could inherit something that the other sister didn't, because again, your DNA is going to be different. So you potentially could get genetic testing, but if you have family members and they were negative, probably you will be negative as well.
Okay.
Well, I'll add to that too. I would go back to just see what panel your sister had and if it was comprehensive, given that the panels do evolve and change. And since she was so young at the age of diagnosis, she can always do update testing as things get added or discovered over time. And given that she was the first person in the family, it sounds like, to develop breast cancer, she is the best testable. But to Dr. Bonev's point, if your sister's not interested in any more testing, other cancer history in the family, it's always an option for anybody.
Okay. Okay, here's another question, and Shabnam, this might be more applicable to you. The question is, I'm 57 years old and don't have a family history of breast cancer. Would I still be a candidate for genetic testing? And also, would insurance cover the genetic testing?
That's a good question. So our genetics, obviously, they're kind of multi-pronged. Your genetics is yours. So if you're interested in learning about it, of course, it's your right to be able to do that. The National Comprehensive Cancer Network guidelines, for the most part, are what insurance companies go off of. Some insurance companies also have their own guidelines that are a little bit more restrictive than the NCCN guidelines. So many insurance companies will not cover the cost of testing if there is no indication, and an indication would be if personal or family history that Dr. Bonev so nicely laid out in the slides in the presentation. So it is something you can certainly pursue. The overall risk that you would have something is likely on the lower end if there is no family history. Usually that's a huge indicator, a red flag. However, if you're Ashkenazi Jewish and you have no family history, you do qualify for testing because of the higher likelihood that someone who's of Jewish ancestry would test positive for a BRCA1 or BRCA2 mutation.
Okay. So another question that just came up is, do gastric cancers include colon cancer? Dr. Bonev, that's probably for you.
I don't think I really understand the question. Are they talking?
I think you indicated gastric cancers as a risk factor.
Right, CDH1.
So the question is colon cancer a gastric cancer?
Yeah, so CDH1 is associated with gastric cancer, and patients are recommended to have a prophylactic total gastrectomy, which is a pretty big surgery with reconstruction. And they are at risk of breast cancer as well. Risk of having like a colorectal would be on the lower end for them.
But is colon cancer considered a gastric cancer, or no, it's different?
No, that would be in a separate category.
Okay, that is different. Okay. Here's another question. Would the 23andMe testing be sufficient? Or actually, what is the difference between like picking up a 23andMe test and doing a test through the CARE program?
So I'll let Shabnam elaborate on this, but the 23andMe, that is focusing more on ancestry. Also, the results are not guiding clinical practice. So true genetic testing would be such as through the CARE program or through a multi-gene panel, but I'll hand it over to Shabnam to answer this.
Yeah, so 23andMe, they do have some clinical genes on there. They do test for the BRCA1 and 2 founder mutations that are known in the Jewish population, but they're not doing full assessment of the entire gene. So if someone does testing and they're negative, that doesn't mean that they can't have a mutation somewhere else in the gene. So 23andMe isn't considered a clinical test. And even if someone is Jewish, for example, and identifies a founder mutation through 23andMe, there's a recommendation in fine print that it be confirmed clinically because, again, it's not a clinical test. So 23andMe shouldn't be used as an end-all be-all. It's something that is interesting. It's fun for people to do and learn about, different fun little facts genetically related, but it's by no means a clinical test. So if there is a family history, if there's, concern, a clinical test would be indicated. And to Dr. Bonev's point, the care program can identify if you are high risk, and then I provide you with the option for testing.
Right. Okay. Thank you. Here's another question. Does having breast implants increase my chances of breast cancer?
So that is definitely a concern among patients. Data out there concludes that it does not increase your risk of breast cancer. There is a risk of lymphoma with a particular set of implants that have been recalled and are no longer used. That's the Allergan Natural implants. However, there are patients who already have them in place because they have them in place before the recall happened. So that would be a risk of a lymphoma that's localized to the breast.
Okay. Another question is, does large breast size factor into being higher risk for breast cancer?
Large breast size, not necessarily. It can impact imaging if the imaging is not sufficiently capturing the whole breast. And sometimes that can happen with patients who have implants too. The breast is essentially being displaced and the mammogram is not able to catch all the breast tissue. So potentially lesions can be missed, but not necessarily having extra breast tissue increases your risk of breast cancer.
Okay. I actually have a question. I have this question. So I read something about breast density now being included in the Tyrer-Cuzick model, which you referenced earlier. So does that change anything in terms of assessing who is high risk?
Yeah, so the current Tyrer-Cuzick model, which is version 8, incorporates mammogram density. So within the report, the radiologist will indicate, as I showed in the previous slides, one of the 4 categories, ranging from either fatty breast to extremely dense breast. And so when you go in the Tyrer-Cuzick program, they will ask which category you are, you punch it in, and then and sometimes what I do is I actually play around with it and I see like, how is their risk going to change? Let's say they're extremely dense, or they have fatty breasts, vice versa. How does your risk change? And you can see how it is. And then of course you fill out the rest of the model, like if you're on hormones, when was your first period, etc. But it can, change it. So I've seen when I have a patient with extremely dense breasts, I'll show them and say, hey, if you had the lowest category, which is primarily fatty breasts, this is what your risk would be. But now, because you have extremely dense breasts, the highest category, see how it jumped. And so you can play around and then, show them the numbers.
Got it. Okay, that's interesting. Interesting how it changes.
Mm-hmm.
Yeah. Okay, well, I think we're gonna wrap it up. It's about time for us to wrap it up. I want to thank you again, Dr. Bonev, for that great presentation. And I want to let everyone know that if you still do have a question and it didn't get answered, you can email it to concierge@breastlink.com. And thank you again. And thank you for Shabnam for joining us. And thank you to Breastlink for hosting this special event. And if you are interested in any more information, please visit www.breastlink.com. And thank you all for joining us today.